Good afternoon, everyone. I'm Dr. Cath Cosgrave, and this is a webinar about Attract, Connect, Stay. Delighted to have you all here. And what we're going to be talking about today is how to attract healthcare workers to your rural community. Before we get started, I'd just like to take a moment to reflect on the meaning of place and connection and recognise the traditional lands we are meeting on today. My place of belonging is Bellingen, a small rural town situated in the hinterland of the mid-north coast of New South Wales on Gumbaynggirr country, and I wish to acknowledge their elders past, present and emerging, and all the elders of all the lands we work, live and learn on, and pay respects to their ancestral spirits with gratitude and respect. Just before we get started, I'll just give you an overview of what this lunchtime special is. Three of us are going to present. So that's myself, followed by Ruth Stewart and then Anna. And then we're going to have a community panel of representatives who have been implementing and are at different stages of the Attract, Connect, Stay solution. And then we'll finish up with a Q&A panel with myself, Ruth and Anna. Please feel free to put questions into the chat. We'll do our best to answer them at the end in the Q&A panel. And if we don't get to all of them, I will go through them all and respond to you directly. Let's get going. So just a little bit about me. So I'm the founder and principal consultant of Cath Cosgrave Consulting. I work as a rural change maker and strategic advisor, research translator and evaluator. I'm a recognised expert in rural health workforce strengthening and the factors impacting attraction and retention. Based on 10 years of research, I have developed the whole of person retention improvement framework, a guide for improving the attraction and retention of health and other professionals to work and live in rural places. Drawing on my research expertise, as well as 25 years of community development experience, I work with rural leaders and change makers to develop community-centred, strength-based strategies, such as Attract, Connect, Stay, to effectively address professional workforce shortages. What I'm going to talk is about what is Attract, Connect, Stay. So I'm going to zoom you through a little bit of research and how we got to Attract, Connect, Stay and where we are with it right at this point in time. So just to be clear, the part that I have expertise in is the attraction, recruitment and retention space. There's a lot of good work that goes on in the development and the pipeline, the training of health professionals, but that's not my area of expertise. So I'm interested in how we can attract graduates and keep them in rural areas. So 10 years ago, I commenced my PhD and I was in search of a good news rural health workforce story. So I wanted to know, why did they stay? And it was an investigation about the employment and rural living factors impacting turnover and retention. And my study was based on early career rural-based community mental health professionals who are working in public health and their experience in their first few years of working. So it was a grounded theory study for any researchers out there. And so I developed a theory to explain this turnover and retention. And what I found was that it was a mixture of professional and personal expectations. And these were weighed up and people were assessing whether their expectations were being met. In the professional factor space, it was about scope of role, workplace relationships, access to continuing professional development and career advancement opportunities. And the mixture of what was important to people depended on their career stage and their time in the job. And so there was nothing new there. That was pretty much what the literature had identified as well. So this study confirmed that. But where my study was progressive and creating new ground was really diving into the personal factors and what was at play there. So what I found was that social connection was integral to retention, and people were weighing up whether the town itself and the community could meet theirs and their partners and family members' life aspirations. And of course, as we would expect, there was quite a different experience between locals who were, or people from the region, and those that were newcomers well up from outside the region. And some other things I found was that everyone experienced a period of adjustment, as I call it, the rabbit in the headlights phase, and that was probably more intense the less experienced health professionals were, and that there was a process of adapting over a 12-month period. At the end of that stage, most people began to weigh up whether the job was for them and living in this community was for them too. What became interesting, or a key finding, was that what people focused on, or what they were initially, it was much more about their professional satisfaction, and they were willing to tolerate a little bit of discomfort in the first 12 months around their personal satisfaction. But after 12 months, that flipped, and the reasons for staying or leaving were strongly determined by the extent of their personal satisfaction. So some other key findings about this study were that attracting and retaining a rural health workforce is complex. There are no simple solutions here because people are complex. The social factors strongly affect the retention of newcomers. The first 12 months is particularly challenging for those newcomers because it's a human need to belong. And rural communities need to be more inclusive and welcoming of newcomers to support them to form social bonds, especially with locals. And health professional workforce strengthening strategies must be tailored for the particular social and geographic context, i.e. they must be place-based, and actively involve residents in their planning and delivery, i.e. we need community to be engaged in these strategies. So on completion of my PhD, I felt a call to action, and I felt there was an urgent need for a person-centered, holistic approach to attraction and retention. So I created the whole of person retention improvement framework, which was based on the empirical research investigating rural health workforce strengthening strategies, particularly in the last 10 years and in countries like Canada, the Scandinavian countries and the UK, and as well as my own research and consultancy work in the last 10 years. Which has involved hundreds of interviews with rural health professionals, CEOs, health service managers, as well as meetings with rural business and organisational and community leaders. So the whole of person retention improvement framework, commonly kindly known as WOP-RIF, addresses an identified need for a person-centred holistic approach to successfully attract and retain health professionals to rural places. So whilst I call it a retention improvement framework, it's as much an attraction framework. If you want to retain, you need to attract ideal candidates and recruit them. So, but the main game is retention, so hence why it was called a retention improvement framework. So this is the retention improvement framework. It has 3 domains that impact retention. There's the workplace organisational component, which is the need to work in a friendly, supportive and inclusive workplace. This is a lot about culture and teams and line managers. The role and career component, which is having opportunities to build skills and access career pathways in the region. And this requires collaboration between health services within the region to offer those opportunities. We haven't done much work in this space yet because we've been too busy with the pink and green section. As well as the community and place part, the feeling settled in and being socially connected and having a sense of belonging. These domains identify necessary preconditions for improving rural health workforce retention through strengthening health professionals' job and personal satisfaction, as we had in that earlier diagram. So what is the Track Connect Stay? It's the strategy operationalising WOP-RIF's community and place domain. So, And how did I get to Wopwith, that this Attract Connects Day? So I was implementing the Wopwith program with two health services in Victoria while I was on a fellowship with the University of Melbourne. And they asked how could they do the community in place component, what was the best strategies, and I didn't really have any. And I looked at the literature in Australia, and there was some around secondary refugee migration, but not very much or nothing really in the health professional space or the professional space. So I applied for a Churchill Fellowship and was successful. And I travelled to Canada in 2019 to investigate community-centred or led strategies to support new to area health professionals and their family members. That's as important in their resettlement and social connection needs. I came across the health workforce recruiter connector model that we call the recruiter connector. That is what Attract Connects Day is. It's implementing this model. And it had been operating in the town of Marathon, Ontario for 10 years. And its achievements were that it was highly successful in attracting and retaining a broad range of health professionals for the medium to long term, as well as there'd been no vacant professional positions since the inception of the position, despite severe health professional shortages operating in the region. So this really piqued my interest and I wanted to know more. And I knew the moment I'd had the conversation with Brett Redden, who's in the middle, who is their recruiter connector, that there was something magic about this model, and it probably was what Australia was needing. So Brett's responsibilities, so he's been in the role now for 13 years, in the Attract Recruit part, is to implement attraction strategies targeting health professionals who are a strong fit for the job and the community. And he works really closely with the health services in Marathon to identify what an ideal candidate is, and then goes out looking for them. So this is him at a medical conference promoting Marathon Ontario. In the settle and connect space, so once they identify and begin to have a potential ideal candidate, he provides individually tailored support to those health professionals and their family members. In fact, he talks about the partners are often more important to ensure that they're satisfied than the health professionals. And he works with them in their settling in needs, including finding partner employment and making social connections in the community. In the stay and retain space, he identifies and addresses systemic problems around local services and infrastructure that are negatively impacting attraction and retention. This can be things like housing, childcare, schooling. It differs for every community, although I'd have to say these days the housing one is common across the board. So the essential ingredients for why this model works is that it's community-led and community-funded. It's funded by the health services that use the service, as well as the local government, council, and a major employer, which in this town, in this community, is a gold mine. And they've all been putting in a contribution every year for the last 13 years. So it's run by a management committee comprising the key health stakeholders. It's a contractor deliverables position, and Brett works flexible hours so he can be responsive to the needs, the attraction and recruitment needs as they emerge. It's very much a customer service concierge service, so everything's tailored for the individuals and their needs and interests. There's a strong level of community understanding and mobilisation in Marathon regarding the importance of having and strengthening their health workforce. And because of this strong community awareness, they celebrate successes when they recruit and when people do things like buy a house or get married. They're all celebrated and shared across socials, and they still have a local newspaper. And so I came back after that trip to Canada, and I was working in the Greater Shepparton region, working quite closely with council And I said, I think I found a model that would be really beneficial for Shepparton. A Community Connector program was funded with some grant funding, and it was part of a bigger strategy about great things happen here in Shepparton. So this is the Community Connector program. It was originally, the first Community Connector was, so the program started in January 21, and Fiona Smolines was the first Community Connector, and we're joined today by Bim Rutherford, who's been in took over the coordinator role in June this year. So we'll hear a little from Bim in a little while. So Attract Connects Day, as well as being a program, is currently a project, and it was funded by the Foundation for Rural and Regional Renewal, and it started in December 20, and we're just about at the close now. And it's administered by Sarah. I'm the project lead. There's a research team of Drs. Malatsky, Waller, and myself. And Dr. Anna Moran, who you'll hear from today too, is the external evaluator. So what we were funded to do was to establish a research-informed website to provide resources and tools to guide rural communities to establish their own health workforce recruiter connector. And how we developed these tools and resources is we drew on the experiences of Marathon Ontario. I spent the first year interviewing, and many of those interviews are on our website. We delved in deeply, and I've been working very closely with the pilot site in the Glen Innes Highlands community, and you'll hear from them in the community panel, as well as looking at other communities who are applying the Marathon model, although they're not actively involved in this project. And that includes the Mid-Coast New South Wales, and in particular Taree, that are working on an allied health model, as well as Greater Shepparton, who I've just referred to. And we also brought in Anna's evaluation findings and other peer-reviewed research that I'm aware of on rural health workforce strengthening. So what's different about Attract Connects Day? It's community involvement in rural health workforce strengthening strategies is essential. So it really leads on this. Community has, and this is why it's essential, because community has the requisite knowledge to ensure that strategies are well tailored for the specific place and community, as well as it helps build responsibility and commitment to supporting the successful integration of any new to area health professionals. Engagement of the community in recruiting and retaining the right health professionals has been described by Roger Strasser as an essential strategic element for achieving a sustainable fit for purpose health workforce. Attract Connects Day is community-led and uses an assets-based community development approach. I assume every rural community has a unique set of skills and capacities that can be channeled for community development. And local people and relationships are the community's most valuable asset. So we launched the website in May 2022, and I've built 3 learning modules, and we've called them to take you through and understand what needs to be done to implement Attract Connects Day. So the first step is, are you ready? Then it's once you decided you are ready, a step-by-step guide to governance, funding, and recruiting your recruiter connector. And I'm currently writing the go part, which is developing resources, particularly for the recruiter connectors and the management committees, recruiter connectors, to how to help health services identify their needs, and for the management committees around sustainability. So that's in a nutshell. I'd now like to introduce Adjunct Professor Ruth Stewart. Ruth Stewart is the National Rural Health Commissioner. She's been a rural generalist with advanced skills in obstetrics for over 30 years. And she has worked clinically in private practice in rural hospitals and clinics in southwest Victoria and far north Queensland. Ruth is the past president of the Australian College of Rural and Remote Medicine, and established the Rural Longitudinal Integrated Clerkship for Deakin University School of Medicine, and was the director of rural clinical training for James Cook University School of Medicine and Dentistry. For 12 years, she's been a board member. She was a board member of the Australian College of Rural and Remote Medicine, for 8 years of Cape York, and then of the Torres and Cape Hospitals and Health Service, a board member of the regional training organisations and of the Tropical Academic Health Centre. Ruth was awarded her PhD for her thesis, Learning from the Development of Maternity Managed Clinical Network in a Low Volume Rural Context, by Flinders University in 2013. So I'd really like to welcome Ruth Stewart. The question I've asked Ruth is why is she so passionate about Attract Connects Day for rural communities? So over to you, Ruth.
Thanks, Cath. Look, I'd like to begin by acknowledging the Bidjara people, who are the traditional custodians of the land on which I stand today, and all the lands where we meet virtually. So I'm in southwest Queensland, Bidjara country. I pay my respects to these elders, past, present, and emerging, and I extend that respect to Aboriginal and Torres Strait Islander people who are participating with us today. You've heard the things that I've done. My current role as the National Rural Health Commissioner is an independent and statutory officer role. There's legislation that underpins it, and I'm supported by 2 deputy rural health commissioners with expertise, one in allied health and Indigenous health, and the other in nursing and midwifery. So my office focuses on supporting urgent and emerging issues. COVID-19 is obviously one of those, but certainly a very urgent issue is rural health workforce. We're also to support innovative models of care and their development, rural generalism in medicine, nursing and midwifery and allied health, and to engage with stakeholders, key stakeholders in rural health. So that's a bit of my background and why I'm interested in this. But let's just talk about what the problem is, what the problems are that we face in rural and remote health. So rural people have a lower life expectancy compared to our urban compatriots. And that life expectancy is much lower for remote, especially remote Indigenous Australians. Now, those statistics are related to the social determinants of health, such as housing, but we know that diminished access and lack of access in some places to healthcare plays a large part. And when there is access to healthcare, we're finding that increasingly there is not continuity of that care, and we know that discontinuous care is less effective and can be downright dangerous. And look, I have a really strong belief that the standard and quality of healthcare should not be determined by our location. I think about it like this. I can't see why the healthcare that I can expect as a remote community member should be any less than the healthcare that my brother, who lives on, not far from Melbourne, should expect. I probably pay more tax than he does. It just doesn't make sense to me. It only makes sense if you think, or if you don't think about it, or if you somehow in some strange world you think that urban people have more value than rural people. That's not my world. So we know that the models of care that have been implemented across rural and remote Australia are largely models that were designed in urban centres for that high density population. And then they've been applied in the rural communities because that's best practice, apparently. I call that geographic narcissism, actually. Geographic narcissism is where you think that your place is the best and can define the best for everywhere else. We live in a world where urban people think like that, largely. So, one of my roles, as you've heard, is to challenge that conventional urban design principle. I want to see service integration, co-design with community, multidisciplinary teams, rural generalism for medicine, allied health, Indigenous health, nursing and midwifery. But to run all of those programs, we've got to have the workforce. So as you'll all be aware, the rural health workforce is in critical undersupply. We know the professional elements required to train, attract and retain a rural health workforce. We know all about them. They include selecting rural origin students into health courses. Cath showed the slide with reference to this. So we want those rural origin students in university programs. We want to provide those students with opportunities to train in rural areas. And we want those opportunities to be extended opportunities that are well supported and recurrent throughout their training. We know that when this occurs, those students are more likely to live and work in rural communities. Now, the University Departments of Rural Health, which is supported by a government program, the Rural Health Multidisciplinary Training, has been doing this for 2 decades. And we are seeing some change. We need to see more change. There has been a recent review of that Rural Health Multidisciplinary Training Program, and we are looking forward to there being refinement of the program to facilitate focus on the things that actually work. Now, often I'm asked, what can we do to get more doctors into rural communities? I like to respond by saying, look, it's not just doctors that we need. People are aware of the fact that we're not getting as many doctors into rural communities because they used to have doctors and they don't have so many now. But the way that we deliver primary health care has changed a lot. We know there are ways that if you have a whole multidisciplinary team providing the primary health care, you get much better outcomes. So we want all members of the multidisciplinary team out in our rural communities, but our rural communities aren't going to, the local newspapers, their local members of parliament and saying, get us a physiotherapist, get us a speech therapist, get us a pharmacist, get us, because at the moment they're seeing the highest priority as doctors. I'm really keen to have people understand that we need the whole multidisciplinary team in rural communities. And we need to have that team working in strong models that provide professional support and sustainable employment. We know that those, when professional support and the strategies to implement that are there, it works to keep people. So that brings me around to what is it about Attract, Connect, Stay that I like. I think Cath's framework provides us with an opportunity to improve our understanding and act on the social elements and strategies required to attract and retain the rural workforce. Attract, Connect and Stay recognises the importance of community involvement. This isn't just about what can the government do for us, it's what can we do for ourselves and our community to attract and retain rural health workforce. And it also recognises the importance of the whole person. So not just who that person is and what they can do when they walk through the door of the workplace in the rural community, but who they are when they are living in the rural community, how they can connect to that community and how they can contribute to it in many ways, not just in their working life. And so the role and importance of a rural, of a recruiter connector within a community is really important, to provide a social pathway for rural health professionals into a new community. So thanks, Cath.
Thanks so much, Ruth. So now we're going to hear from Dr. Anna Moran, who's been the evaluator. So I'm just going to put a screen up for Anna and tell you a little bit about Anna. So Dr. Anna Moran is the founder of Unplex, a consultancy that works alongside health and disability organisations to create evidence-based roadmaps that guide impactful decisions around workforce and service capacity issues. Anna cares deeply about individuals with health and disability needs and the staff that work hard to meet their needs. She gets frazzled by organisational inefficiencies and roadblocks that often lead to staffing issues and prevent people accessing the care and support they need when they need it. Stemming from almost 20 years' experience as a clinician, private practice owner, health services researcher, evidence translator, facilitator, rural health advocate, mentor and project manager, Anna has developed a passion for and expertise in looking at and presenting issues differently so they can be managed effectively. Welcome, Anna. And
thank you, Cath. Thank you, Ruth. And I'd just like to quickly acknowledge the Wairau and Dadaroa people as the original and ongoing custodians of the land on which I stand today. And I'm going to have a crack at sharing my screen. Please ignore the mess that it looks like initially, and we'll crack on with the presentation. Here we go. There we are. Okay, so a whistle-stop tour. Cath challenged me today to talk about, does it work and how do we know? So I'd like to acknowledge that I've worked alongside Cath. I've known Cath for about 6 years now professionally, and I've worked alongside her for the last 3, and it's been an absolute privilege to be part of this program. And I would say that my role in those 3 years has been as an embedded evaluator, and that means that I have worked alongside the communities that she's brought on board to help coach them through implementing a community connector or a health workforce community connector. And the importance of that has been, firstly, when you work alongside communities as an evaluator, you work with them from the outset. So you help them to work through their planning processes, but within that, you're helping them to develop the systems that they can use themselves to monitor the impact that they're having and to do that in an ongoing way. So clearly not a great business model for me. And second purpose of being an embedded evaluator is that I get to feed back to Cath on what's working and what's not. And because of that, the Attract, Connect, Stay program is able to iteratively improve and develop as we go along. I've worked in health services research for a long time. It's a privilege to work with Cath in that community space and the asset-based community development. So it's a nice fusion of that community development approach and the health services research hat that I wear. I use realistic methodologies, which is a funny term that helps to overcome that geographic narcissism that Ruth described. And it really is examining what works for who, why, and to what extent. And each rural community has different levels of impact and different reasons why that works. I'm just checking that my screen is still shared. There we go. Okay, so moving on to, yes.
I'm just stopping you because I can't see anything on the screen share. I've just got a black box that says Workforce Recruiter Connector.
That's exactly
okay. All right, cool.
So today I'm presenting an overview of all of the iterative information that's come together over the last probably 3 years working with Shepparton, the Grampians and Attract Connect Stay Glen Innes. So I'm going to start with this graphic here. This represents what the Community Connector role epitomises, working with all of these stakeholders, community and council, industry partners, employers and workplaces, community groups and local businesses, and new to area employees and their partners and families. The Community Connector role, as you can understand by the word connector, brokers these relationships and connects these relationships, so stands in the centre of that connection. So what do we know about impact so far? We know that these roles allow for net movement of highly skilled professionals to rural townships. They increase the awareness of opportunities in rural townships. They allow for an increased awareness of the needs of the community. And I've bolded that one because the two-way arrows on the diagram show the importance of this role. Not only are they gauging information from these community groups, they're absorbing this information from all these stakeholders and then distributing that to the places that information needs to go. So these guys are strategic in ensuring that there is impact on multiple levels of the community. And we've also seen a whole of community commitment to undertaking strategies to attract skilled professionals. This is a no small feat, but we have certainly seen this demonstrated in Shepparton. Marathon has had this for years. Glen Innes is on their way, and we've seen it starting off in the Grampians region as well. So in terms of a workplace and workforce impact, we've seen improved retention of healthcare and other highly skilled professionals. And I say early because we've only really been monitoring and evaluating this for the last, it's coming up to 2 years in Shepparton now, and they're still seeing some great wins in that space. We've seen improved recruitment to hard to fill healthcare roles, turnover savings for local businesses and organisations, and importantly, an improved understanding of the application of the principles that Cath talked about earlier today. And finally, and most importantly, is we've seen significant individual level impact. So on those new to area employees, their partners and their families, we've seen high levels of satisfaction with the program, high intention to stay among those new to area professionals that have been supported by these roles, professionals staying beyond 12 months, positive experiences of moving to rural communities, early engagement in and with the rural community, and developing a sense of belonging. So lots of great impacts we've seen. So the key mechanisms that we know that need to be in place to facilitate this success are these, and Cath has already identified a number of these in the Marathon model and has described how Attract Connect Stay has operationalized this. But when you evaluate what's been going on in these rural communities, these are the mechanisms that need to be in place to enable those impacts to be realized. I've put in bold a couple there, that the health workforce recruiter position needs to be flexible and tailored specifically around both the new to area professional needs, but you'll see the other images in this picture. It needs to be tailored around employers and workplaces and the community groups, but also at that council and industry level. Everybody supports it. There's engagement and buy-in from all stakeholders. Everybody recognises that it's a hard work solution. It's not a quick fix. One of the important things that we've observed is that the steps need to be followed. So the Attract Connect Stay steps that Cath's talked about, that ready, set and go, the steps that are in there must be followed in order to have a strong foundation for success. It has to be community funded, and I'm sure Bim will talk a little bit about that, and Sharon a bit later in our community panel discussion. There has to be excellent governance structures in place that facilitate open and impactful lines of communication between all stakeholders. That's a really important one, lots of words in that, but that really goes to just putting words around those arrows that you can see in this image here. It's so important that there are really clear lines of communication that bring all of these stakeholders together and enable the community to thrive. So it's too early to really measure the success of the Attract Connect Stay program in terms of the project that we have undertaken through the Foundation for Regional Renewal. So I'm just going to give you a little snippet of where we're at in Attract Connect Stay Glen Innes. What I would like to say is that the foundations are there for future success for Glen Innes, and they're to be congratulated on all the hard work that they've done adhering to those mechanisms that we know needed to be in place for this to work in their community. So just to regroup on those, these are the mechanisms that are in place currently in Glen Innes and that have contributed towards some of the wins that they've had. And I'm sure that Sharon will talk to some of these in the community panel discussion. So they've followed all the steps in the Attract, Connect, Stay program, and it's led to a very strong foundation for them to build upon. They have, and this is probably one of the really key ones, and Ruth has worked in communities that certainly have this. In Glen Innes, there is a very strong, shared, deep and personal connection with the impact that health workforce struggles have had on them as individuals and their community as a whole. And this was identified as one of the key factors that has led to them being able to bring everyone on board and having a shared want for this program to work in their community. The Health Workforce Recruiter Connect position has sufficient autonomy and flexibility that it can tailor support to both new to area professionals and liaise and work well with local community needs. There needs to be early and ongoing engagement and buy-in from a diverse range of stakeholders. And again, I'm repeating myself from the mechanisms that we know need to be in place. Glen Innes has done an exceptional job at putting this in place. They've done the hard work. They've funded their program 100% from the community, which is a pro and a con, and I'm sure Sharon will comment on that a little bit later in the panel discussion. There are excellent and clear governance structures that allow the community connector to do her work and the committee to do their work, and then for them to come together and compare notes and bring progress things forward. The success indicators that they want to use to measure impact have been developed within the committee and with the Rural Health Connector, and there's a community of practice that has surrounded the health workforce community, the Health Workforce Recruiter Connector, to make sure that she is supported in her role and she can tap into the resourcing that Cath can offer and some of the other sites that are on the panel discussion today. So what are some of the quick wins that we've seen for Glen Innes so far? There's over 200 Glen Innes members who have financially contributed to funding the Health Workforce Recruiter Connector position. They have assisted one GP to begin work and to settle into Glen Innes, and highlighting one of their success indicators here, they've collected this information themselves. This has meant that 70 patients have moved off the waiting list. There's been 224 additional clinical care hours provided over 3 months. And just all of those wins there, which should be celebrated. There's 2 further GPs in the pipeline, but I need to say that these are not confirmed yet, but they're hoping that that will come through. An exercise physiologist, diabetes educator, nurse practitioner, speech pathologist. 2 last points there are that the Health Workforce Recruiter Connector has done an incredible job of mapping the current healthcare services that are available in the community and trying to bring those stakeholders together so that there's a better alignment and continuity of care between all those services. And finally, she's done some work to engage the GP practices in that organisational component so they understand the factors that need to be in place in order to retain those newcomers. So my final slide is really just to say that the key finding really is that you need to lay strong foundations in order for this program to work. It's not a quick fix and it takes time. Thanks, everyone.
Thank you, Anna. So we're running a little bit behind, so I'm going to go straight to the community panel now and introduce them here. So the community panel is Sharon Nels, Ben Rutherford and Mark Drury. So Sharon is the chairperson of Attract, Connect, Stay Glen Innes, which has been in operation since January this year. Glen Innes and myself have been in communication. We started talking in April 21, and it took about they were selected as the pilot site, and then it took them about six months to establish themselves as an incorporated association. That was the decision this community made. It looks different in every community. Sharon's, as I said, the chairperson with a very active committee, and they put in place their recruiter connector after they raised the funds to do so in about July this year. So, and we're lucky enough that she's a retired GP, so she's right across the health workforce issues. Bim Rutherford is the current Community Connector Coordinator for Greater Shepparton Council and the Community for Greater Shepparton. This program's been running for almost 2 years now. It has been reliant on grant funding and some support from the Greater Shepparton Council and Committee for Greater Shepparton. It's been very successful. They've particularly initially focused on the the Connect space. And one of the differences about the Shepparton model is it does all professional workforces, although I would say about 70% of the people that they assist are health professionals. So just some differences there. And Mark Drury from Dundaloo Support Services in Taree, who's the CEO of Dundaloo, is also a member of the Attract Connect Stay working group in the mid-coast of New South Wales, and Taree is looking at running an allied health professional Attract Connect Stay model, and they're in their early phases of ready, and Mark will talk to you about those. So just panel, we're running short on time, so if I could ask you to be mindful of that and stick to your 3 minutes. I'm going to stop sharing, and so the question we've asked them is, what have been your main wins and biggest challenges so far? So we'll probably just have 5 minutes of Q&A at the end, yeah, we will watch your chat, please, presenters, and we'll have to stop you if you run over. So I'm going to stop sharing, and over to you, Sharon.
I thought it would be useful if I was to give to contextualise this to the Glen Innes context, to tell you what I perceive as being the things that have led to those wins in Glen Innes in this 12 months that we've been operating. The most important thing is that we had a committee that was ready to participate. Our council had been running a series of think tanks around the big issues in our small rural town, and you won't be surprised to hear that our healthcare workforce was primary amongst those. So we already had a committee that had been talking about the problem, but was ready to embrace a potential solution. Attract Connect Stay came to our community at a time of crisis. One of our 3 practices was going into retirement, and that was going to release several hundred clients back into an already overloaded system. That will be quite common experience to all the listeners on today. Glen Innes was selected as a pilot project for the Attract Connect Stay model following an expression of interest process. That meant that we'd already done some significant thinking and analysis before we went into the project, and I believe that has worked towards giving us a good foundation. It also gave us access to Dr. Cath Cosgrave for guidance, strategic direction, and Anna for the ongoing evaluation. And these are the robust structures that you need to succeed. It was also important that we had an excellent committee of highly skilled people in our community to drive the project. We were able to recruit a solicitor, a chief financial officer, myself, I'm a retired health bureaucrat, and a local person who had a background in training and recruitment. So that was quite a strong little executive committee that came together and has worked very hard over this 12 months to bring it to fruition. I went on a speaking circuit, and I think this was really important to building the strength of the project. I had to stop speaking. I went for 6 months and then had to stop because everyone in town had heard the presentation. But it built an understanding of the model, and that was really important because they had to understand that we weren't going to be solving the problems of the health system. We were going to be building and strengthening from the bottom up. growing a constituency and building community support. We were successful with a little low-level local grant funding, which was non-recurrent, but allowed us to get a kick-off kit, which bought us some of our setup gear and allowed us to apply some of those funds that we were raising in the community directly to the project. One of the things that's been really important is implementing those stages of the Attract, Connect, Stay model and watching it come to fruition. Engaging the local healthcare practices has been critical, with the healthcare recruitment advisory group being formed. And then, of course, the big issue for us, as it would be for everyone, is raising sufficient funds to actually take the risk and appoint the healthcare recruiter, the recruiter. That was a huge relief and a big celebration, and that was at the 6-month mark. Our biggest challenges, you won't be surprised to hear, were raising the funds. It's a small rural town. There are competing priorities for local funds. We looked for innovative ways to fundraise, and that gave something back to the community. We have a business sponsorship program framed around the concept of a robust healthcare system is everybody's business. We have a series of little hearts that we've designed, which are a window decal to go on shop windows and car windows and so on. And that's given to everybody with a donation over $1,000. Another big challenge was we were juggling COVID, of course, throughout this entire period. So there were stops and starts and meetings online and meetings offline. And of course, we all go into hibernation up here. We're not as cold as Marathon, but we are a cold town and we have a long, cold winter. So things tend to go a bit quiet during the winter. Our biggest challenge is ongoing financial sustainability. We've looked now into adding some grant funding into our model, including, I believe, very soon some success around a small grant to look at the feasibility of expanding the remit of the model more into the community connector model, picking up some of those other areas of the economy who also suffer workforce shortages. And now going forward to our annual general meeting, which will be growing and enriching the community. So we're looking to another business event, which will be a report back to the community. We hope at that one to introduce the new arrivals, which Dr. Anna so well listed, and set the groundwork for our next year on our annual general meeting. So that's us from Glenna's, a hardworking, busy little community and great fun.
Thanks so much, Sharon. Straight over to you, Bim.
Thanks very much, Cath, for the warm welcome and warm introduction. It's really great to be able to share some of our experiences of the Community Connector program in Greater Shepparton. Shepparton's been really lucky to have a proactive council and business group that really understands Attract, Connect and Stay to our region's workforce. Excuse me, Shepparton's biggest employer is Golden Valley Health, who is also our largest partner of the program. Since inception of the program 22 months ago, we've relocated 332 new to area professionals, which is amazing, and their families, which is most important, with nearly 50% being referred from GB Health themselves. A few of our successes I'd like to share with you quickly is that we've brokered great relationships with our real estate agents, and that's allowed us to develop priority application for the process of relocating new to area professionals, particularly that 80% of our staff now for GB Health are coming from overseas. We've created a short-term housing platform to avoid rentals, to fill the void of short-term rentals when professionals first arrive. We've worked closely with businesses and industries to provide connections for partners looking for work. And I feel like this is something we've done very successful, and that's through brokering our relationships with business partners such as Grow Greater Shepparton, to have a job seeker platform there. And as we know, to settle that partner into work, and those social connections are really important. The retention statistics that we have in the last 12 months is that we've had 4 or 5 professionals leave Shepparton in that time, and they're usually over a variety of reasons, from job satisfaction, job offers, or just family situations. So again, the retention statistics are quite amazing. The program really is the eyes and ears of attraction and recruitment in Greater Shepparton, and we have that ability to collect data. We survey our clients at a 6, 12 and 18-month timeframes, and we share and collaborate with networking groups in Shepparton. We provide that data to councils and appropriate working groups, and we also, that basically helps shape our strategic planning going forward and our resources and tools that we've developed as well. We've had great success with program partnerships. Quickly, La Trobe University with the engineering prep program. We've worked with University of Melbourne and La Trobe with the teachers pre-service teaching program, which is based in Shepparton as well. Some of our challenges, and actually our main challenge, is really the sustainability of the program. Growing too fast, relying on funding, which we received last May, which was an additional 300,000 funding for a 12-month period. And that finished up in May. The funding was amazing. It allowed us to inject additional staff. We employed administration assistants. We were able to partner and develop programs, which was being brilliant, but it also it also brings us to now the program being unsustainable with myself as one staff member to run the program, which the momentum is quite is brilliant in the town. We're currently developing a fee for service model for local businesses and stakeholders to see the continuation of the program past June 2023. And we anticipate that looking around about 2 to 2.5 full-time staff to continue the program and to support our local businesses going forward. Yeah, that's a quick overview of some of our wins and certainly some of our challenges going forward. Thanks for your time.
Thanks so much, Bim. And straight to you, Mark. We're going to probably, we'll run over and record the Q&A, but if anyone needs to go at 2, at 1, that's absolutely fine. So straight over to you, Mark. Mark, you're on mute.
Yeah, do you need me to shrink this down to a minute or so, or what do you want to do?
Yep, that's great.
Okay. All right. So straight into it. Four wins and 4 challenges. Probably the main win for us was that the business community got behind us straight away, and Mid Coast Council got behind us straight away. And something that is really, really important to note for us, I think for the whole program, is that you really need people who have strong community influence to be able to get behind this, because allied health clinicians, they tend to have connections, but they don't have the ability to be able to pick this up themselves and run with it and put it into place. You need to have people who have really strong connections in the community. And so we had really good linkages straight into council. The business chamber recognised the opportunity, and they were very happy to be the governing body for this. And we're in the process of putting together the management committee at the moment. Surprising to us, Mid Coast Council were the very first major contributor. I mean major. They really got behind this, and there were no strings attached. In fact, they just said, don't even think about getting us to have any sort of governance in this. It's just way too complex. It'll make it muddy. You guys just handle it. The only stipulation was, if you don't manage to make this happen, give us our money back. So that was about it. That's the only thing. And the other really good thing, the public sector, I don't know about anywhere else, but for us, it's a bit of a barrier between public and private sector. But the public sector have been really willing to come to the table, and we've recognised that they don't have the ability to quickly come up with funds. That's a long-term thing for them. But what they've been able to do is bring some really good ideas that are on the peripheral of the program, which is things like being able to form collaboration where we can have some concepts of clinicians from the private sector and the public sector swapping places and actually spending time in each other's areas And for them to be able to come to the table with those sorts of ideas, I think it's pretty significant, even though they can't contribute financially just yet. So the main challenges, this is the first one. Cath is awesome at delivering her research, and it's a no-brainer when people listen to her that it's the obvious path that they need to go with. But we have struggled to articulate that for ourselves. And that's something that we've got to work with. We just haven't got it right. And every time that we've really tried to articulate it to somebody else to sell it, we just haven't got it right. So we've had to have Cath back a few times to actually use her to be able to keep the momentum going. We've got really good momentum around the concept, and we've got really good drive to make it happen. But allied health in general, all they go, yeah, we need it, this is awesome, let's do it. And when we ask for the money, they're very reticent to be able to hand over the money. So that's something we have to work on as well. Overcoming the user pay mentality and recognising that a larger contribution doesn't equate to a higher level of service or first dibs on potential candidates. And lastly, working together for the greater good, even though we're competitors, has been a challenge for the larger organisations because they want to protect their patch. On the opposite end of the scale, the single clinician operators are happy with their workload. There's plenty of freedom to currently choose what their load and scope is. So in that sense, shortage is a good thing because they don't have to chase clients, but it's not necessarily a good thing for quality. Thanks, Cath.
Thanks a million, Mark. So I just want to, so what the next steps are, I really encourage you to get involved, take a shot of this QR code, jump on to the Attract Connect Stay website. I really encourage you to subscribe to our mailing list so that you're up to date with developments and case studies as we begin to populate the website. And you can request a free consultation with me as well. So we're just going to continue with some of the questions, record those so you can jump in. I apologise for running over. Everyone's enthusiasm and commitment to the program has meant that we've all got lots to say. So I thank all my panelists and my community panel. Thank you so much. And I'm just going to jump in. And so Ruth's had to go, but she's watching if there's any questions that I particularly want to direct to her. So I'm just going to jump in to the Q&A and read this first question. So, is there any potential benefit to multiple communities within the same geographic region working through this model program together and supporting each other? Or does it need to be very separate in individual communities? I really encourage you to, it's a complex answer to this. I really encourage you to jump onto the Ready module on the Attract Connect Stay website, where I explain in some detail what is an ideal sized community. But Mark, if you don't mind, I'll perhaps talk about the Mid Coast Council, which is an amalgamated LGA. It has 3 quite large population settlements and many villages in between. So for that one, we chose to start, we will scale up over time to the whole community, but we may actually need to have recruiter connectors in each of those places. It's hard to know, we recruit from community, and it's hard to know and have the connections in a region as much as we need you to have the local connections with lots of people and businesses and community groups within a local area. So it just depends on the size of the local government area. So Glen Innes is the whole LGA, and that's appropriate for the size. So that it has 1 major town, but Taree is the start of that program down there. And Shepparton's a very large area with, and so as Bim has mentioned, she probably wouldn't mind having a team, and Anna and I have evaluated their program, and that is our recommendation, that there definitely needs to scale up for the demand or the risk of high burnout. So let me just have a look of other questions. Is it just a supply problem? E.g., will the Attract Connect Stay Towns just be stealing off other regional centres? Q and Bruce, could you send that to Ruth? But I'll have a go at answering it. Unless Anna, do you want to have an answer on that one?
I think the only thing that sprung to mind was your point about every rural community has things that it offers different people. And so what you're looking for in your Attract campaign is somebody who is a good fit for your community. And so this notion that you're stealing someone, which I get, I think it's such a hyper competitive workforce market at the moment, but there are some people perhaps who don't want to move to the beach and who might prefer the highlands of Glen Innes. And that's all about how you describe the appealing parts of your rural community. And every community has multiple different appealing parts. And so there will be a good fit somewhere that perhaps you are competing against good fit types with similar kinds of attributes that match your community. But yeah, that's all I have to say there, Cath.
Yeah, and I'd probably agree wholeheartedly. I mean, there are supply issues are outside my area of expertise, but based on, and we certainly know until fairly recently, allied health has not been a supply issue, it's been a maldistribution issue. And that's about attracting the right people for your community, for your health services, and really strengthening your Attract and understanding why people would want to move to your town, live there and thrive there. So yeah, and I'll just see, is there anything more? No, I think that's it from us. So I'll get everybody to the panelists to come off their mutes and say goodbye. Thank you so much. Again, my apologies for running a little over. We'll do some, as we call it, snippety doodah, and get this to fit within an hour. Thank you so much. Please jump onto the website, have a look. We're currently evaluating, so we may pop you an evaluation of what you think. All that helps us build better resources for communities. So we're really passionate about doing that. If there's any questions we've missed, I will go through and answer and share those with Ruth and Anna, and we will respond to you directly. So thank you so much. I hope you got to eat your lunch and have a good day. Bye from all of us.
Thanks, everybody. Bye.
Yeah.
Bye.